In this session, we will discuss how to select subjects and measure variables. This is the 7th topic in the research design course. We've discussed how to ask an answerable research question, search the medical literature, and the design of observational, interventional, and diagnostic studies. The goals of this session are to select subjects that are representative of the population of interest by defining inclusion and exclusion criteria, understand the types of variables, review the precision and accuracy of measurements, and review methods to sample subjects. When we design a study, we start with a research question. We decide on the population of interest to answer that research question and enroll a sample of that population. We then collect and analyze data, draw conclusions from the data, and extrapolate those conclusions back to the population of interest. In this session, we will discuss the methods to choose a representative sample. The study enrollment criteria should optimize the rate of the primary outcome. For example, if you are studying appendicitis, you would include patients with right lower quadrant tenderness rather than all patients with abdominal pain. It is also important to select a group that would benefit from the intervention. For example, if you are studying the effects of epinephrine on bronchiolitis, select patients with moderate to severe disease, in whom it is easier to see improvement. It is difficult to demonstrate a difference in patients with mild disease. The sample should be representative of the target population to ensure generalizability. In general, a sample population should have the spectrum of disease in the population. For example, if you're studying appendicitis, you would include patients with and without perforation. Patients should be selected to optimize recruitment and ensure compliance with the intervention and follow-up. The inclusion criteria should define the disease severity, the demographic characteristics of the sample population, including age and gender, the season of illness, for example, summer for trauma and winter for bronchiolitis, and the setting of the sample population, for example, a trauma center or a community emergency department. Exclude patients susceptible to adverse effects of the intervention. For example, exclude those who are allergic to the intervention, have comorbid medical conditions, or who are pregnant. Exclude patients with co-treatments that may interfere with the study intervention. To ensure you have adequate power, consider the proportion of patients who will decline consent, may be non-compliant with the intervention, or may be lost to follow-up. Remember that your study results will not be generalizable to the patients that you exclude. All relevant variables should be identified prior to data collection. Essential variables include demographic characteristics of the sample population, independent variables including predictors and potential confounders, and dependent variables including measures of efficacy and safety. Whenever possible, variables should be defined in a manner consistent with the existing literature. Independent variables include both predictors and confounders. Predictors should be based on the study hypothesis and include any factors that have a potential association with the outcome in the literature. Confounding variables covary with predictors and may mask true associations. In this study, the predictor was a prior history of febrile seizure, and the outcome was developing epilepsy. An independent variable underlying neurologic disease is a potential confounder for the development of epilepsy. Underlying neurologic disease could be an exclusion criteria or could serve as the basis for a relevant subgroup analysis. For example, the development of epilepsy in those with and without febrile seizures can be stratified into those with and without underlying neurologic disease. The dependent variable is the primary outcome. The choice of an outcome should balance clinical relevance and feasibility. If you are studying the efficacy of medication for migraine headaches and the existing literature uses 2-hour change in pain, then you should use 2-hour change in pain as well. Outcomes should be patient-oriented. For example, initial studies on statins showed that they decreased cholesterol, a surrogate measure for cardiovascular risk. Only in later studies were statins shown to decrease cardiovascular morbidity and mortality. It should be possible to assess outcomes accurately. Use a validated scoring system, and if none are available, then assess inter-rater reliability of the outcome assessment. Assessors of the outcome should be blinded to the study groups. Plan for relevant subgroup analyses. The other dependent variables are secondary outcomes. Secondary outcomes are typically a mix of efficacy and safety outcomes. Additional efficacy outcomes add weight to the primary efficacy outcome if the results are of the same magnitude and direction. Safety outcomes always include adverse events. In essence, every treatment study is also a harm study. Remember that the study is powered for the primary outcome and not powered for rare adverse events. Variables should represent the item that they measure. For example, the Glasgow Coma Scale represents the risk of death from head trauma, and a visual analog scale represents the degree of pain. The goal is to minimize measurement error. Measurement should be precise, that is free from random error, and accurate, that is free from systematic error or bias. Validity in relation to variables asks the question, how well does the variable measure the phenomenon that it intends to? Content validity is when a variable contains all aspects of the item under study. Construct validity is when a variable shows a difference in two groups that differ in the outcome. And criterion validity is when a variable correlates with an acceptable existing measure. Whenever possible, use validated instruments. They have the advantage of being consistent with prior studies without the need to validate a new instrument. There are methods to analyze text data, but most data is converted to a numeric scale for analysis. Numeric data can be categorized as continuous or discrete. Continuous variables can take on an infinite number of values, and the difference between measurements is consistent and quantifiable. For instance, blood pressure and temperature are continuous variables. The measurement of continuous variables is only limited by the sensitivity of the instrument. In contrast, discrete variables can only take on a finite number of values. Discrete variables can be further divided into ordinal variables and nominal variables, also known as categorical variables. Ordinal variables represent ordered categories without a quantifiable difference between categories. Ordinal variables can be numeric, such as the number of patients, or non-numeric, such as the Glasgow Coma Scale. Nominal variables are named only and have no inherent order. For example, blood type is a nominal variable consisting of type A, B, AB, and O, with no inherent order among them. Dichotomous variables are nominal variables with only two categories, such as yes or no, and positive or negative. The variable fever can be recorded as a nominal, ordinal, or continuous variable. A nominal fever variable would include febrile and afebrile. An ordinal fever variable would be hypothermic, afebrile, febrile, and hyperpyrexic. A continuous fever variable would be temperature in degrees centigrade. Always collect the variable with the highest information content. If you collect temperature as a continuous variable, you can later convert it to an ordinal or nominal variable. If you collect temperature as a nominal variable, you cannot later convert that to an ordinal or continuous variable. When measurements are precise, they are less variable and there is more power and less sample size required. Precision can be affected by random error and be due to variability in measurements by the observer, the instrument, or the subject. Precision can be assessed by reproducibility. Precision of continuous variables is typically assessed by a coefficient of variation, and for categorical variables by a kappa statistic. You can enhance precision in measurements by standardizing the measurement method, training and certifying observers, piloting data collection forms and surveys, automating the instrument to avoid human error, and by making repeat measurements. In contrast to precision, accuracy is the degree to which a variable represents what is intended or real. The term validity is often used to refer to accuracy. Lack of validity is referred to as systematic error or bias. Examples of biases include observer bias, in which there is a distortion in perception, for example, asking leading questions in a survey. Subject bias, in which there is a distortion in measures, for example, recall bias in retrospective studies. And instrument bias due to a poorly calibrated scale. Accuracy is often assessed by comparison to a reference standard. Mean or median differences from the reference standard is used for continuous variables. Correlation or test characteristics are used for discrete variables. You can enhance accuracy in measurements by standardizing the measurement method, training and certifying observers, and automating and calibrating the instrument. The first three methods also enhance precision. Accuracy can also be enhanced by making unobtrusive measurements to avoid the Hawthorne effect, which is a change in subject behavior when they are aware they are being studied, and by using blinding to avoid ascertainment bias. To summarize, precision is defined as reproducibility and is assessed by repeated measurements. Precision results in decreased random error and variability and an increase in power. Accuracy is defined as validity and is assessed by comparison to a reference standard. Accuracy results in less bias and systematic error. Once you have defined the enrollment criteria and the study variables, it is time to select your sample population. We will discuss how many patients to sample in our next session on sample size determination. The two primary methods of sampling a population are convenience sampling and probabilistic sampling, also known as probability sampling or random sampling. There are several probabilistic sampling methods that we will discuss in the coming slides. Convenience sample is the most common method used in clinical studies. For example, consecutive patients are assessed against enrollment criteria based on the setting, time, or staff availability. Convenience sampling is not based on randomization. However, it has advantages in cost and logistics. Effort should be made to minimize volunteerism and other types of enrollment bias. Subjects who agree to participate in a study may not be representative of the general population. Probabilistic sampling, also known as random sampling or probability sampling, is based on the concept of randomization and is the gold standard for generalizability of the sample to the population of interest. A simple random sample obtains a subset of the population. For example, of a population of 300 pediatric asthma visits to the emergency department in a year, 50 are chosen with a random number generator for inclusion in the study. A stratified random sample is used to obtain enough patients in a subgroup that is not well represented in the population. For example, subgroup A is not well represented in population X. In a population X, a random sample of subgroup A and of subgroup B are obtained. For example, there are 1,000 asthma presentations to the emergency department over a 2-year period. However, severe asthma exacerbations are rarer than mild and moderate asthma exacerbations. A stratified random sample may include 100 patients each presenting with a mild, moderate, or severe exacerbation. A cluster sample is used when there are too many patients to identify and sample. This may include a random sample of natural groupings, such as a random community sample based on zip code. Periodic sampling is a type of systematic sampling and could include, for example, every third patient. Though systematic sampling is considered a type of probabilistic sampling, it is not truly considered to be random. In summary, subject selection involves specifying inclusion and exclusion criteria. Demographics, predictors, confounders, and outcome variables should be clearly defined. Effort should be made to enhance the precision and accuracy of all measurements. And probabilistic sampling based on randomization may improve generalizability compared to a convenience sample. On to our questions. You are designing a randomized clinical trial of a new medication for migraine headaches and are determining the inclusion and exclusion criteria. Which of the patient characteristics below should not be part of the exclusion criteria? Allergy to a medication in the same class as the study medication, inability to speak English, likely to be lost to follow-up, or pretreatment with an analgesic. The answer is B, inability to speak English. Patients should not be excluded from enrollment based on a non-English primary language. Enrollment should be equitable. The principle of justice in clinical research entails that the benefits and burdens of research be equally distributed. Patients who should be excluded are those at increased risk from participating in the study, such as those with an allergy to the study medications, those with potential confounding characteristics, such as those with significant comorbid conditions and a pretreatment that could confound the study intervention, and those who are unlikely to comply with the study intervention and unlikely to be available for follow-up. Which sampling technique is an example of convenience sampling? A sample of consecutive patients presenting to the ED, a random sample of a proportion of presenting patients, a random stratified sample of 2 subgroups of interest, a random community sample based on zip code, or enrollment of every third patient? The answer is A, a sample of consecutive patients presenting to the ED. Convenience sampling is the most commonly used sampling technique. However, it may be susceptible to enrollment bias because it is not based on randomization. For example, a convenience sample of patients enrolled based on investigator availability from 9 to 5, Monday to Friday, may be biased if patients presenting on evenings, nights, and weekends have different characteristics. Answers B to E are all examples of probabilistic sampling. Which of the following techniques would not improve the precision of a measurement? Standardizing the measurement method, training and certifying measurers, automating the measurement, making unobtrusive measurements, and repeating the measurement. The answer is D, making unobtrusive measurements. Making unobtrusive measurements could enhance the accuracy of the measurement by limiting the possibility of the Hawthorne effect. That is, the possibility that the study subject may change behavior based on their awareness of being studied. Blinding is another method to enhance accuracy. The other answers are techniques that enhance both precision and accuracy. The next session in our research design course will discuss how to determine what is an adequate sample size.